Good morning. I hope all of you joining us today are safe and healthy. But if any of you are not, we truly wish you the best. My name is John Etchemendy, and I'm one of the co-directors of Stanford's Institute for Human-Centered AI, or HAI as we call it. I'm here with my co-director, Feifei Li, and we're pleased to welcome you virtually to Stanford University and to HAI's Spring Conference on COVID-19 and AI. The subject of our spring conference was originally going to be the intersection of neuroscience and AI. But with the onset of the pandemic, we were faced with a decision. We could either postpone the conference until fall, or see if we could convert it to an online format. In the end, we decided to delay the original conference, but to see if we could provide a more urgent public service. A conference focused on the many ways that AI can be used to better understand and address the multiple threats posed by COVID-19. Given we had only weeks to plan, it's a tribute to the public spirit of the research community that we could assemble the remarkable expertise represented on the agenda today. I'll let our other hosts describe the topics and format that we have planned for the day and the mechanics of the individual sessions. Ironically, the fact that we were forced to make this a virtual conference opened it up to many participants who would not otherwise have been able to join us. While our original conference was sold out at less than 800 attendees, over 10,000 signed up to join us today. And since the attendance is not limited, we expect many more to drop in. We're delighted to welcome you all. Feifei, would you like to add anything?
Thank you, John. It goes without saying that I wish we were gathering under very different circumstances. In just a matter of weeks, the world around all of us has changed. Personally, when I wake up every morning now, my first thought goes to my elderly parents in their mid-70s, living in one of the hot zones of California with chronic health conditions. As the coronavirus rampages around the world, changing societies in unprecedented ways and claiming lives as we speak, I am sure all of you are in one way or the other concerned about your loved ones and your community. Many of us are sharing a sense of vulnerability physically, socially, or economically. Yet as a scientist, it is also reigniting the sense of urgency and meaning to the work we do. In these trying times, I am especially inspired by the eagerness and diligence of scientists, clinicians, mathematicians, engineers, and social scientists around the world who are coming together to combat this pandemic. A crisis like the COVID-19 outbreak presents challenges that touch many areas of life and span many fields of expertise. They don't lend themselves to easy solutions or quick fixes. But however challenging or daunting, the journey towards solutions must begin. So what role can AI play? AI, machine learning, and data science are a set of related technologies that is really good at finding patterns. In the last 2 months, much work around the world by researchers have been about finding patterns. In the virus biology and genome, in the infectivity and the spread of the virus, in discovering drugs to treat the virus, in the public and personal responses to the virus, and much more. So we wanted to bring together researchers in these areas to help illustrate the ways in which human-centered AI can help in complex, rapidly evolving situations. Almost exactly a year ago, Stanford HAI was founded on the idea that AI can serve humanity's best interests when it's guided by a diverse, inclusive range of expertise and perspectives. Today, we're putting that ideal to the test. It is part of our mission of ensuring that AI is always part of the solution, not part of the problem. With that, I'd like to introduce our moderators for the day, our good friends and associate directors of Stanford HAI, Professors Russ Altman and Rob Reich.
Thank you, Feifei and John, for your welcoming remarks. I'm Russ Altman. You'll hear from Rob in a moment. HAI, as you just heard, is really pleased to bring this conference. I'll remind you of a few things. We decided to do this on March 3rd, so this is very much a best effort. Please bear with us as our technical and logistical challenges in moving to the online format become clear. The speakers we're very grateful for. In general, these are the most critical, most busy folks right now, and so we're so grateful that they joined us. Now, I'd like to say that although AR is our clear focus, we were not strict in applying this lens in all the work that we invited. Sometimes we just included really interesting talks that were adjacent to or related to AI. Now, human-centered AI mandated a broad look at how we can help in this pandemic. So you're going to see 4 sessions today. The first one is on framing and landscaping. What are the challenges that are really facing us with this pandemic? The second one is the social and cultural implications of this work and how AI can help. The social and cultural implications of the pandemic. The third session is the epidemiological and other methods for tracking the disease. We've all seen maps. Where do those maps come from? How can AI inform them? And finally, there's going to be a session on the treatments, vaccines, and healthcare challenges for COVID-19 patients. Our goal, of course, is to provide a balanced and multiple perspectives to best illuminate the challenges and the opportunities facing the scholarly community as we try to help in this battle against the pandemic. Now, I want to take a moment for thank yous. Very soon, now or a minute ago, you will see a slide or have seen a slide of our team who worked tirelessly for the last 3 weeks. I want to especially thank Professor Michelle Ilam right at the middle at the top there, who is our co-organizer with Rob and I. I want to thank the team who put this all together. I want to thank the Stanford video folks who are helping deliver it. Of course, we want to thank the speakers in advance of their comments. And we want to thank you, the audience. We are pleased to see a global audience. And in our initial signups, we saw participants around the world, including large groups from Canada, India, China, the UK, and many others. So as you heard and as you've surmised, our format today is entirely virtual. Every speaker is in a different location, and this will pose some technical challenges. Please bear with us if there are technical glitches during our time together. I apologize if there are funny behaviors of Zoom backgrounds. We're doing our best there. You may hear funny sounds in the background. Sorry about that. You will hear voices with time checks. The only way we can tell our speakers that they have a minute left is to say 1 minute left. So you will hear that. And I want to apologize to our speakers because we may have to cut them off if they're going long. We understand their enthusiasm, but we have to keep to the schedule. If the signal goes down for this meeting, please go to hai.stanford.edu, where you came this morning, for alternative ways to view or hear the conference. Now, just 2 more things. We invite you to ask questions during the broadcast. Please go to the COVID-19 conference page, the HAI site, on the website, and you will see an Ask Questions link. We will try to get to as many of the questions as we can. Rob and I have a small army of colleagues passing the questions to us. And finally, we are pleased to offer continuing medical education for today's conference. If you know what CME is and you want some, please go to the COVID-19 conference page on our website and click the CME link. As I said, our day is divided into 4 sections, and our goal is breadth. We'll take brief breaks between the sessions and try our best to stay on schedule. You will hear some voices for timing. I'd like to transition now to our first section of the day on landscape and framing, and therefore pass it to my colleague and friend, Rob Reich, Professor of Political Science at Stanford. Take it away, Rob.
Thanks a lot, Russ. I'm going to serve as the co-host for this first session on framing and landscape. Let's get right into it in a minute, but I just wanted to add one additional note to the entire conference today. As Russ said, we're entirely virtual, each of us in a different location, stitching this together through the wizardry of modern technology. One thing that I think is interesting to note for the entire day is that we're members of Stanford University. It's a global conference. universities often work on very long time horizons. We measure the time in semesters or academic years. Research takes a long time to grow and then mature. And in the face of an emergency like the coronavirus, universities have mobilized to act quickly. As Russ said, we put this conference together in the space of less than 30 days. Universities were amongst the first places to act and to shut down the campus locations before states and cities did. And this conference is just one example of the many different things that universities across the world are doing in order to respond to the crisis. So our first session is about landscape and framing, setting the tone for the day. We've got a batch of fantastic speakers, and I'm especially excited to introduce our first speaker, Congressman Bera, who will provide some of the opening context for us before we begin the agenda for the day. We will have some Q&A with Congressman Bera directly following his remarks, but because he's only available for a brief time, we won't be able to take audience questions just for this portion of the session. So let me now introduce Congressman Bera. With a 20-year medical career as a doctor and as the former chief medical officer of Sacramento County in California, Congressman Bera has long been a strong advocate of American leadership in global health. He is one of only 14 MDs, medical doctors, serving in the House of Representatives of the United States. He was the first member of Congress to hold hearings on the coronavirus issue and exercise oversight of the federal government's response to COVID-19. He was also among the first people to sound the alarm when the White House disbanded the office in charge of preparing for pandemics and sought to include funds to combat coronavirus over 2 months ago through other legislation. I'm really pleased to welcome Congressman Bera with us today. Congressman, you can now start your slides and start your screen.
Great, thank you. Thinking about how we ended up where we are today really helps us frame where we're going to go. If we look back over the last decade or two, many of us have understood that we were going to see a pandemic coming. We went through SARS, we went through H1N1, we saw MERS, and then the 2014 Ebola outbreak. And many of us actually thought we were fairly lucky not having something like what we're dealing with right now with COVID-19. That's why global health security and the global health security agenda was one of the first key areas that I got involved with when I got elected to Congress in 2013. It's difficult to sound the alarms because it's a small community of folks that are focused on pandemic preparedness. But post the 2014 Ebola outbreak, I think President Obama understood that there were some things that they got right, but there were also some things that they were slow at. So we did a deep dive in 2014 on lessons learned. And that's when you elevated this pandemic preparedness czar to the national security level. We thought that was clearly one of the most important things that we could do, to have someone who was working across the agencies, but also working with the international community and was just paying attention to small outbreaks as they popped up. And that did serve us well during the Zika outbreak. You had early warning signals. You had someone who was in charge of tracking how the outbreak was moving along. You had someone who could talk to the various agencies and make sure we were prepared, and also interact with the public health apparatus here domestically and internationally. You touched on the fact that that position was disbanded in May of 2018. We sounded the alarm at that juncture. We questioned Secretary Pompeo and really said this was going to make us less prepared. We've continued to try to fight to get funding for this. So fast forward to December of 2019, those of us in kind of the global health security space started to hear reports coming out of China that there was a novel coronavirus that was occurring. And then early January 2020, you saw the unprecedented shutdown of Wuhan and Hubei province. And that's when we knew something was going on. CDC, to their credit, had been trying to get to the hot zone prior to that, and we're not being allowed to get into China. They did have some personnel there, but the best way to get information is to get into the middle of the hot zone. That unfortunately didn't happen. Our first briefing was January 23rd, when the administration briefed both the Senate and the House. That was Tony Fauci, Bob Kadlec, Director Redfield, and others. And the focus at that time from the administration perspective was all on a containment strategy, which was really a travel ban out of China. We sounded the alarms at that juncture, and in the first hearing that we had in Congress in the first week of February, that a travel ban was fine. It was not going to contain this virus because the virus doesn't see borders, and it had already likely traveled outside of China and potentially, as we determined, had likely traveled to the United States already. It would buy us time, and that in that time we really needed to prepare our public health apparatus, make sure public health departments, hospitals had the supplies that they needed, and we were pushing testing. We lost time, unfortunately, as the CDC decided to devise their own test. I think there was a false sense of security when they announced that they were sending the test out to 50 states and to public health labs. We lost an opportunity there because we assumed that that test was going to be an accurate test that could be quickly ramped up and brought to scale for the massive contact tracing that we needed to do. Unfortunately, we can't get that time back. Fast forward to early March when we had the first community-acquired case of coronavirus in Solano County, ended up at my old hospital, UC Davis. And that's really when it came to light how little testing capability we really had. And that patient ultimately tested positive. Thankfully, that patient has recovered and is back home. But that's when the real alarm bells sounded. And we're only a month away from that point where we started to change the testing criteria and get the CDC to change the testing criteria to where we are today. If you look at the second week of March, people started to put in social distancing measures in Seattle and California. Fairly early on, Governor Newsom here in California, as the first state, went to voluntary stay-at-home orders to fairly quickly to mandatory stay-at-home orders. New York was a little bit after us. Washington State was around the same time as California. We will, as we see this virus kind of unfold across the globe, as well as here in the United States, you're seeing in real time how important those stay-at-home measures were. For my home community here in Sacramento County, what it did do is it really does look like it slowed the spread of the virus. Again, we still expect that we are going to see a peak in a wave perhaps in a week or two, but it did give our hospitals capacity to prepare, the ability to get protective equipment as they could, and hopefully bought us some time to ramp up our diagnostic testing capabilities. Unfortunately, you've seen other states like Florida and Texas that have still not issued mandatory stay-at-home orders statewide, and we've been pushing the administration at the federal level to issue that order as opposed to leaving it to 50 states. I hope Florida and Texas don't get hit as hard as New York, but we will see in real time almost this case control study that's playing out of early states versus late states. And if you watch the president's conference yesterday with Dr. Fauci and Dr. Birx, kind of showing that those graphs, you'll see that we are leveling out in California and Washington, are not going up as fast. And then if you look at New York and New Jersey, unfortunately, and Louisiana and other places, you're seeing this dramatic rise. Let's fast forward and how I think big data and artificial intelligence can help us with the next steps. The conversation in Congress is now moving to, we've got to mitigate this. We've got to control the crisis at hand. We've got to help our healthcare professionals and the public get through the immediate crisis. But we also have to start thinking about what those next steps are. And we are starting to have those conversations. We're also paying attention to Korea, to China, to Singapore, and other places that were a month or two ahead of us in this. So the first thing and first tool that we really need is serologic testing. From that perspective, I think Stanford has the serology and others. So we have the test available. We are now working with the commercial sector and making sure the funding is there to massively ramp up serologic testing. And why that's important, it's different than diagnostic testing. Serologic testing will tell us how many people in the community have already potentially been infected by COVID-19, recovered, and have some level of immunity. That will help us make scientifically based decisions on when can you open up parts of a certain community, when can you open up parts of the country. That massive serology, I think this is where having the ability to use big data to sort through a lot of that and get a sense of, what is the level of immunity, not just in one particular part of the country, but all across this country. So that's going to be very important in helping guide us. A second big issue is it really does seem like there's a temperature sensitivity to this virus. And if you go to the Johns Hopkins website, and they're doing a great job kind of collecting the data on number of cases, numbers of death, and where they're appearing. If you look at the northern hemisphere versus the southern hemisphere, it is quite shocking. The northern hemisphere is all red.
1 minute.
Southern hemisphere is not. So looking at that data, that's going to be extremely important as well. And then the last thing, we've talked about distributing thermometers to every American. As we start to reopen, training them to check their own temperatures. That's going to be a big data set as well. And that could be, as new clusters pop up, it could give us some information on how to move forward. And again, big data is going to be very important in teaching us about this brand new virus. So I will stop with that, and I'm happy to take some questions.
Thank you very much, Congressman Bera. We do have a couple questions for you. And I wanted to begin just by noting that just today in the news, the Secretary General of the UN called this the greatest threat to the globe since World War II. You're a member of the subcommittee chairman, in fact, of the House Foreign Affairs Committee. I wonder if you can speak to some of the global challenges, not just domestic challenges, and perhaps even the opportunities for US leadership to coordinate a global response, precisely for the reason, of course, that the coronavirus doesn't respect national boundaries. And to combat this globally requires global coordination.
Absolutely. The United States is uniquely suited with the resources to, and with the leadership, hopefully, to push the global community to work together here. This is where we've got to learn from each other. Part of the reason why we sounded the alarms early with China is because we actually wanted to learn from China. And I think this is a place where China can really be a world leader as well. We know that there's a high risk of a second surge potentially in the fall if this is a temperature sensitive virus. And how can we get through the current crisis, but also get prepared for hopefully not another surge? We also know if the southern hemisphere is going to be hit harder, places like Africa and elsewhere where they don't have the public health infrastructure could be hit pretty hard. How do we take what we're learning now to help prepare those that may get impacted later?
Russ, do you have a question as well?
Yeah, Congressman, thank you very much. I was wondering if in DC, anybody is yet thinking about how we're going to unroll shelter in place. I'm sure many people wonder about this, and especially if it's going to be coordinated or if it'll be a county by county basis as it was stood up.
I think in an ideal setting, you would have the federal government coordinating with the states and the local public health authorities. You'd also have the science guiding this. That isn't how this unrolled in preparing for this pandemic. Hopefully we've learned from that and we can do this in a coordinated manner. We do think specific geographies and communities will probably open up first, likely because they were hit first. We have to know what level of immunity exists in a community, and we can start then releasing those folks that have some level of immunity back into the community, either to care for folks that are still ill or to get the economy going again. You'll hear this debate about whether we use face masks on the general public to also reduce spread. We're in the process of getting the CDC to change their guidelines. We do think once we've taken care of our healthcare workers and first responders, then it probably does make sense to make sure the general public, for a limited time, does use that protective face mask. And then it's probably bifurcated. We know there's a very high risk population of those over 60, but really over 70 and 80 that you may have to treat slightly differently, particularly they're very vulnerable versus those under 50. And again, this is where working together as a planet, sharing data, looking at what best practices are, we can learn from each other.
Let me hop in there as well with a follow-up on that. I'm sure many of the people who are watching are looking for a game plan about how we get out of the shelter in place for the very many people who are currently abiding by those orders. Can you say something about what your expectation is with respect to testing, which has been such a difficult issue here in the United States? When can we expect to see much more widely available testing, and how is that connected to getting us out of the shelter-in-place orders?
You know, we've been told a lot by the administration that the testing's coming. I'd listen to Dr. Fauci when he does the press briefings. I do believe Abbott does have a point of service test that should be ready and distributed fairly soon. We're going to need that to make decisions about reopening. And we also know when we're starting to reopen, we will still see pockets of clusters emerging, and we have to have the ability to go quickly into those clusters and do contact tracing so we can contain those clusters if we have second events, et cetera. There's two different types of tests, and it's incredibly important for us to understand. The diagnostic test, which will tell you whether you have the disease or don't have the disease, and the serologic test will be a blood test. It likely will be a finger stick blood test that will tell you if you have immunity to the disease, if you were infected, maybe you never had any symptoms, and now actually have some levels of antibody. That will also be incredibly important in helping us make decisions about how safely to reopen.
1 minute.
Okay, let me ask a final question here. I'm curious if you can say something about how this whole crisis goes far beyond a medical or public health crisis. Some people are calling this the first modern infodemic. And as a public official in a position of responsibility for the health of the country, the well-being of all people, what can policymakers do at this point to ensure that people are getting accurate information? And not being subject to misinformation and disinformation that we see often online.
That's a challenge because early on you saw it coming from the highest levels of government, from the Oval Office briefings. Going forward, we're going to have to learn from this. We're all going to be changed by this because we're all going to be impacted personally in one way or another. What it also is doing is it's accelerating technology changes. The fact that we're doing this video conference, and we're all working from home, et cetera. So those societal changes are going to have an impact as well. So how do we learn from today, but also rethink where we want to be in the future? And I think that's going to be the big challenge for policymakers as well as industry and individual leaders.
Congressman Bera, thank you very much for your time this morning. We're grateful to you for showing up and participating in this virtual conference.
Thank you. Be safe and be kind to one another.
Thank you. All right, now let's move on to the remainder of our first session on landscape and framing. At this point, we will begin taking audience questions, and you'll be able to ask a question by going to the link on the website that says join the conversation at hai.stanford.edu. I'd next like to welcome our speaker, Nigam Shah. Nigam Shah is a professor of biomedical data science at Stanford University. Nigam, you can share your screen and slides now. Welcome.
Thank you. So this is a story that is spanning multiple departments. I'm just a messenger here. This is the work of over 60, 70 colleagues who got on the same page at this URL below. And it's Stanford internal. So if you're a Stanford person, you can access it. It is not a public document, but I'm going to walk you through the highlights. And this is sort of our take as an academic medical center to see what we can do to help respond to this pandemic. So if you can go to the next slide. So the overview is that in such a situation, there are multiple kinds of information needs. So the first bucket is operational planning. And there we might need to know things such as, how many patients do we expect in our region? How many floor beds are we going to need? How many ICU beds? How long will our PPE last? The second bucket is clinical care decisions. We just heard that testing had been limited. Who do we test? Can the presenting symptoms help us screen people better? Um, and then the last bucket is these broader research questions that drive the science. What are the drugs that might alter clinical outcomes? What are the characteristics of the virus of the patients worldwide? And all of these are efforts that several of our faculty are already engaged in. And let's walk through the first couple of them. So if we go to the next slide, here there should be a blue box with the information sources that are available to us. These would be sources from the region, such as the county public health department, the census breakdown, and then institutional sources from our testing facilities and so on, because we were amongst the few places that started testing very soon. These sources give us estimates of the growth rate and the disease burden in our neighborhood, and some internal signals about how often is a test coming positive, what is the rate at which we're admitting people. And then if we go ahead, that feeds into 3 different kinds of modeling efforts that help us plan hospital bed and resource use, that allow us to project county level information, and also estimate policy impacts. All of this then feeds into our resource planning, which is geared around planning our surge beds, modeling our protective equipment usage, and then also partnering with our county. And as one of our county officers put it beautifully, can we think of the county as one large hospital? And I think that's the right sentiment to plan with. And then lastly, that as we're doing all of this modeling, we also learn some clinical insights, such as, for example, the co-infection rates with other respiratory viruses is high. And as a result of that, it is not okay to test for, say, influenza, and based on that, rule out COVID. What I want to now focus on is that there's 2 kinds of models that are going around that most of you probably heard of by now. There are these things called SEER simulations or epidemic simulations that capture the dynamics of the epidemic. These tell us the impact of the policy interventions that help us answer when can we get out of these shelter-in-place situations. And we need 10, 12 diverse inputs for these, which are all practically guesses at this point. Then there are these simple calculators that tell us about the next few days. These take very few inputs, cases, hospitalizations, bed capacities, and then help us plan for the next 5 days, so to speak. So here's a screenshot of an epidemic simulator. This is from the OpenAI group. And the point here is there's many such things out there that give you this beautiful epidemic curve, but what we need is accurate inputs. And I love this quote from 538 that says, think of making these models like making a pie. But then if your recipe says, add 3 to 15 chopped apples, steaks, or Brussels sprouts, depending on what you have, well, that's going to result in a differently tasting pie. And it's a good way to think about these complex models, that despite everybody's best efforts, we don't yet have accurate inputs. And so what we started doing is to say, can we focus on getting the accurate inputs? So here's a plot from the Santa Clara County of the number of cases and hospitalizations. And typically what happens is you would start with this blue dot, a case estimate, in this case as of March 16. You would then guess how many infected people are there in the county. Based on that guess, you would project how many will need a hospital bed, and then that gets you your number. But because there's uncertainty in these estimates, these numbers could vary between 1,500 to about 380. And I'm just going to do a back and forth. Now that's about a 5-fold difference. And that's highly uncertain. You can't plan a hospital with that level of uncertainty. So we said, well, we're also tracking hospitalizations. Can we not just use that same series to project where the next dot is going to be? That's where this question mark is flashing back and forth. And so that's what we started doing. And the URL below will walk you through our planning around that. But our suggestion is use hospitalization data from your local region for the health system. You'll be much better off in your capacity planning. And then remember this 12 to 14 day lag between interventions like staying at home and then peak demand for hospitalizations. And day-to-day variation can be misleading, and we got to be watchful about that one number trends down doesn't mean that we're out of the woods yet. But California has been amongst the most forward-looking and amazingly efficient in responding to this situation. So in order to help other people use this kind of hospitalization data, as well as share our planning about our own hospital and so on, and to use it for others, we release these calculators. The URL is on screen right now. There's one that helps you do hospital bed and resource use projection. And then the second one allows you to do your county level or regional hospitalization predictions. The red box shows you that you can use confirmed cases or hospitalizations as inputs. The person highlighted here, David Shankar, is sort of the person who led this large team to get all of this done on a very short notice. So kudos to that team. And then I'll just like to give you a flavor for the kinds of things we're monitoring as an institution. This is sort of our situational awareness. We're looking at the neighboring counties. We're looking at case rates, hospitalization. How are the ratio of new cases changing over time? How is the number of new cases changing over time? And all of this feeds into our modeling efforts that then informs our hospital and our neighboring counties and our peer hospitals that how should we think about this situation and be prepared. And then lastly, I'll zoom out a bit. So all of the things that I talked to you up till now were how are we responding to make sure that we're prepared. But at the same time, we do need to understand what's going on in the population. And another group of faculty, Eleni Linos and Julia Simard, are running the Stanford coronavirus study. And then Dr. Rusty Hoffman and Steve Goodman are running this daily health check, which is actually going to be launched very soon, I think today or tomorrow, so that we can monitor what is going on with people. How are they feeling symptom-wise? Are they getting testing? And then inform that larger geography information in our planning and response. So that's sort of the gist of the effort. And I'll end with this URL that if you have questions that you believe the Stanford data science team may be able to answer, please submit them here. This is a public URL. There's no guarantee that we can get to every question that you submit, but we will try our best. And I'll stop here.
Thanks so much, Professor Shah. For everyone listening, you get a good sense here of the ways in which an interdisciplinary approach, bringing all of the resources to bear of people who work within a university, can help inform this coronavirus response. So it's not just a matter of providing bedside healthcare with issues of masks and PPE and tests, but how data scientists can produce important models that will predict the path of the outbreak and how to provide a better response from within hospitals as well. At this point, we're going to move to our next speaker. So I'd like to introduce Dr. Seema Yasmin. Dr. Yasmin is the director of the Stanford Health Communication Initiative, and she's going to talk to us today a bit about the issues in responsible reporting about coronavirus. Dr. Yasmin, please share your slides and your screen.
Good morning, everyone. Thank you so much for having me. I am going to start, sadly, on a personal note. I know for many of us entrenched in the numbers of this pandemic and studying it from a very academic perspective, it's also a very personal crisis. And yesterday we learned that a dear friend and mentor and phenomenal HIV researcher, Professor Geeta Ramji, died of COVID-19. And she was South Africa's chief scientist for HIV, director of the Medical Research Council's HIV research unit, and she had dedicated decades of her life to HIV prevention research. So as much as we are studying this pandemic, we are also, I think it's fair to say, really heartbroken and stunned by the loss of our colleagues. So I am a public health physician and a journalist. And I came to combine these careers, which may not sound like they should be combined, because I came to the States to serve as an officer in the Epidemic Intelligence Service. So I would be helicoptered into different hot zones and tasked with having to investigate contagion, to stop disease spreading, and to keep people safe as much as possible. And what I noticed very early on, and time after time with many epidemics, was that disease was not the only thing that was spreading. And yet my sole focus was containing a pathogen. What I would see, though, was that rumors, pseudoscience, health hoaxes, all of those things were spreading in tandem with the disease. And those were often helping fuel the spread of infection and leaving communities vulnerable to the disease and also to the spreading misinformation and disinformation. So I decided, after training as an epidemiologist and public health physician, that journalism is part of the public health ecosystem. And in order to be an effective public health physician, I needed to train as a journalist and learn how to share this information effectively. So I did that. I became a television reporter and a newspaper reporter, covered many epidemics, including Ebola and Zika, and then came to Stanford in 2017 as a Knight Fellow to really study how can journalists better cover epidemics and pandemics? How can we make sure we stay safe while doing our job? And how can we ensure that we do the best possible job at countering so many of these false narratives and making sure that people receive the information they need to be empowered, to make informed choices, and to stay healthy? Being a journalist covering epidemics and pandemics is really tough. You are thrust into a dynamic situation with numbers changing every day, and you have to make difficult decisions. Here's just one example from this pandemic. On March 7th, an Italian newspaper receives a leaked memo from an official with plans for a potential quarantine in northern Italy that would effectively restrict the movement of 16 million people. Now, if you were an editor at that newspaper, would you or would you not share that information with your readers about what might be headed their way? I don't know how you might make that decision, but this is the area that we're looking at. So what happened was the story was published. I believe those editors and reporters felt like it was in the public interest to share information about how this pandemic was evolving and how officials felt like they should be responding. So what happened? There was chaos. The leaked plans about the coronavirus quarantine sent thousands fleeing to train stations and bus stations to try and get the heck out of this area that they believed was about to go under imminent lockdown. And the next day, Italy reported its highest day-on-day cases from COVID-19 to that point. Of course, we saw things get much, much worse there. So I share this example to illustrate this point that you have to make tough calls, not just as public health officials about should you or should you not institute restrictions on movement, but also as journalists covering a public health crisis. How do you balance the ethics of keeping your audiences really informed about what's happening and also holding officials to account? And journalism has impact. And that's why many of us go into journalism, because we believe that information can empower people. As I mentioned, during a public health crisis, you can see a disease spread widely, but you see information spread widely as well. There's misinformation that spreads, that's false news that spread without the intent to cause malice. And there's also disinformation, which is false news that spread with the deliberate intent to cause harm. I won't go too much more into this idea of misinfodemics, which is what I study and I'm very interested in, because you're going to hear later from folks like Renee DiResta, who are experts in this field as well. There are many studies that show that false news can actually spread farther and faster than accurate information. So that's what we're up against during crises like this, not just a virus spreading at speed, but also harmful false news. This has happened many times before, not just with this pandemic. Here are just some of the rumors that we saw circulating during the Ebola epidemic. These can have very real consequences on the ability of people to trust healthcare providers, to seek treatment, and to be honest about how sick they might be feeling. We saw disinformation campaigns during the Ebola crisis. Yahoo News's Twitter account was hacked with this false news, that there was an Ebola outbreak in Atlanta. There were more sophisticated breaks too, with a CNN website being duplicated and false news put on the homepage, alerting the public to this false outbreak of Ebola in Atlanta. A lot of this was done by the Internet Research Agency in Russia, with the idea of causing chaos and diverting emergency resources away from where they were really needed. I want to make sure that we're really hitting home the point that, yes, we are in a pandemic situation now. This is a crisis.
1 minute.
But in terms of these misinfodemics, we are up against this all the time in terms of growing anti-science movements and anti-vaccination movements. So this is by no means a new phenomenon, but I hope that we start taking this much more seriously as a public health community and making sure that when we deploy epidemic investigators like I used to be, that we're making sure that we're tackling not just the spread of disease, but also the spread of information that can hurt people. Just some more examples. We've seen Twitter bots and trolls stoking debate around vaccine safety where there is no debate. You may have heard of free press being described as the immune system of a democracy. And that's completely true. I think that you can use journalists effectively to counter false narratives, to hold the powerful to account. But unfortunately, my research has found that journalists are not well supported to cover public health crises. I've said time and time again, we need to make sure our reporters are safe and well trained in how to cover health and science. When I did my research, I talked to top editors at news organizations around the world, and many said they had no plan for covering a pandemic. And many of us in public health will say over and over, but these kinds of things are imminent. We've heard of folks saying they're winging it, and this is exactly how we wind up with reporters sick with the same infections they're trying to keep us informed about. Working on some solutions, don't have much time to get into them, but you can please reach me afterwards if you'd like more information about inoculation theory or the toolkit I'm producing for reporters. And in summary, we just really have to take seriously the concurrent spread of not just disease, but also misinformation and disinformation about disease. Thank you so much.
Thank you very much, Dr. Yasmin. We're going to hear next, our final speaker is Dr. Michelle Barry, who's professor of medicine at Stanford University and directs the Global Health Initiative there. Dr. Barry, if you're with us, can you share your screen and start your slides now?
Yes, I can start my, and can you hear me?
Yes, very good. Thank you.
Great. Thank you very much and good morning. So I've been asked to talk a little bit about the global response to COVID-19. And I think I'll start with this snapshot of various countries with different curves. And I'd like to address the 3 of these countries in a territory that have been able to flatten their curve and talk about why that may be so. I'd like to concentrate on South Korea. Let's go back to that curve. I guess I can't go back. I'd like to talk about South Korea, China, Hong Kong, and Singapore. And the reason I'd like to talk about this is these were very vulnerable countries and a territory that were proximate to the initial outbreak in Wuhan. And I thought it was very interesting. I asked my research associate to look at how many people traveled from Wuhan before those 2 weeks when the first case and before Wuhan closed. And you can see that 5 million people traveled. So you can understand why this virus globalized. Next slide. It's not moving. Okay. Singapore's strategy was one of strict containment. And they took a very strong travel restriction with strict international travel. All returning citizens had to stay at home for 14 days. They had aggressive temperature screening at the borders, all buildings, all airports, and they had rapid test development. And I think what was really key is not only did they gear up their testing, they had pretty much lax requirements. You did not have to be short of breath. You actually could be tested with just a clinical suspicion by your doctor. There was free testing, and at one time, at their peak, there were over 2,000 tests done a day. So this was the first country to have a confirmed and the highest confirmed cases out of China but they were very quick to do strict quarantine measure. They did not have to lock down. They did not shelter in place. What they did was temperature testing in just about all public spaces, stay-at-home notice. And if you go to the right-hand side of your screen, this is a stay-at-home notice where everybody, you can see that we're coming from a country that might have been contaminated, got to stay at home. They got text messages sent to their cell phone. The government followed their cell phone with GPS so that they knew they were staying in the quarantine area. They might, and this is a little card that was given out, they could get random calls from house visits, from authorities, and they would have to take a picture showing that they were in the quarantine area. So it was quite strict quarantine. The other thing that they did, which I think was really important, was that when somebody was identified as COVID positive, they gave them mandatory hospital or isolation stay. They did not put them back in the house. As we know from the China epidemic, in the first 82,000 cases, most of that transmission, 85%, was within a family setting. So positive people were put in hospitals or isolation facilities. They gave aggressive daily economic assistance for everyone quarantined. They told physicians that even if someone was not COVID positive, all upper respiratory infections were quarantined for 5 days, even if COVID-19 negative. Because we know that our swab testing now at best has about 75% sensitivity. They did strict social distancing, but they did not lock down. What they also did was a unified government response and very transparent communication. You can see that they had daily reports on your WhatsApp messaging. They talked about how many cases were in Singapore, how many were discharged. They gave daily messaging about the situation in the country. They also ran very interesting, as apropos of SEMA's communication, comic book chronicles of COVID-19, where they talked about not only what you should be doing, which we get the 5 all the time, but they talked about the sense of social responsibility. Don't come into work for if you're sick. They developed a very interesting app called Trace Together, where actually these are cell phones with this app that communicated with Bluetooth networks and enabled contact tracing for 21 days. And actually, these apps could calculate the distance between people. So you knew if you were coming close to a COVID-19 person. It allowed for early notification, and it was installed by more than 600,000 people in Singapore, and it's now freely available. The benefit of this was that not only were people better informed, the Minister of Health was better informed about who needed quarantine. The con, and we can talk about that, is privacy. Next slide. Let's see if I can do it. Next country I'd like to talk about is South Korea. And what they did was interesting because they did do a lockdown, but what they did was very vigorous testing. And they also prevented people from coming in. They mobilized companies for rapid test development of 100,000 kits a day. They had 600 testing centers around the country. The government asked many of their manufacturers to doing it. And they conducted over 300,000 tests at peak. And I'll show you some of the comparison testing that we can see. So you can see here that we are way below the amount of tests per million people. And that was a very strong reason for why South Korea was very strategic. They had advanced contact tracing using big data with security cameras, smartphone apps, and credit cards. Their data became very transparent. They had regular text message and aggressive thermal imaging at all restaurants, hotel, and large buildings. And they rapidly had new laws to prioritize community security over individual privacy during the outbreak. But again, they were able to do containment with a lack of strict lockdown movement restriction. China's strategy, we all know pretty much about, but I just want to highlight some of the interesting approaches they took. We all know that had a very bold, aggressive approach that strictly controlled movement via quarantine and social distancing. They expanded their hospital infrastructures very quickly with 3 new hospitals and 16 temporary hospitals in Wuhan. They did swift testing development. But what they did, I think that was quite extraordinary, is they had rapid deployment of 40,000 healthcare workers to Wuhan, and they sent 15,000 epidemiologists to do aggressive contact tracing. And it's about contact tracing and isolation and quarantine that I think helped China's ability to stop this epidemic. As again, unprecedented surveillance. They even had drones that sensed temperatures and determined who in the crowd had a fever. The benefit was that with these drones, the police were able to enforce strict social distancing and monitoring fever. Hong Kong took a similar strict social distancing. They implemented this very early in the crisis. They prevented, at the beginning, when they had international travelers coming in, they quarantined everyone and even gave tracing bracelets to those coming back so that they could keep tabs on where they were being quarantined. And interestingly enough, they had daily public releases of COVID positive cases. And this information, you could go online. It had the date of positivity, symptoms, street location. So you knew in your building who was positive, date of discharge from the hospital as well. It was de-identified. There were no names, but obviously there was quite a bit of information that was released. So why did I think about these 4 responses? Because I think they all had something in common. For one thing, Singapore, Hong Kong, China, and South Korea all had extensive, a first preparation, a first run with the 2003 SARS-CoV-1 epidemic, which had about a 30% mortality. So they were set up to do aggressive fever and fever clinics. They had swift and decisive physical distancing. They had aggressive, transparent testing, and they had frequent coordinated public announcements on a daily basis. I did want to spend a few seconds talking about a very interesting public health experiment in Vo, Italy, which shows that containment is possible if you test early. And this is, as you know, Italy is a hot center, but this is a town of 3,300. When they had the first Italy death, they closed the town's border. They implemented mass testing of all residents in February with no new cases. Mass testing, even if you were asymptomatic. And what they found that 3% of residents were positive. They quarantined them, they isolated them, and they did second testing several weeks later and found that had dropped and actually contained it. And since March 23rd, they have not had a single case. Iran is an interesting clash of religion and public health. It was very interesting to see the Iran curve dramatically go up at the beginning, and one asked why. And this was an interesting class of religion and public health. This had to do with the fact that in Qom, Iran, they had 700 Chinese Muslims coming from Wuhan that actually went to a very sacred shrine where they actually licked and kissed the shrine. This obviously caused massive viral dissemination, and still to this day, it's been very hard to interfere with this shrine in Iran. They have now done aggressive, punitive violation quarantining. So we've had a diverse global response to COVID-19. We see how United States has surpassed China, but we've done this not by so much a unified public health messaging. We have state-by-state health policies. CDC cannot go into a state without being invited. We've had lack of testing, which Congressman Bera talked about. We've seen in India massive lockdowns, forcing massive migration, and obviously congregation that is not good for migrant workers. And I think you're going to hear from Jason Wang, a real success story, which I didn't touch upon, which is Taiwan with big data analytics. I want to end with the sense that we need to have this concept of interdependence, sovereignty, and shared global governance. Congressman Bera talked about this. This is not only for air pollution, climate change, but also pandemic infectious diseases. And I think the way that we need to go forward in the future is this concept of we need to have a healthy planet to have healthy humans. We need to look at the impact of our land use and deforestation, which moves these bats, which carry coronaviruses. We need to look at climate change upon emerging infectious diseases. We need to do surveillance to detect emerging zoonotic diseases in animals and humans. And if you want, we can talk later about what this concept of IHR and One Health is, which is basically looking at animal health as well as international regulations and global health security. And lastly, we need to have evidence-based interventions with AI helping us to build community resilience, to prevent, adapt, and respond to pandemics. Thank you.
Wonderful. Thank you very much, Dr. Barry. And now I'd like to invite all of the speakers from this morning, Dr. Yasmin as well as Dr. Shah, to rejoin us. And Russ, if you're back with us too, why don't you start off with a question for any of the panelists?
Yes. Thank you very much, Rob, and thanks to the speakers. Thanks especially to Nigam for dealing with our technical issues and forging new territory. So we're very grateful that you took one for the team. So I think this question is really relevant to everybody, which is the quality of data. We all know within AI, data science, and all the fields that you're in, journalism, global health, and within a hospital, that when you're building models or responding to challenges, your actions are only as good as the data you have. So I'm wondering for each of you, how do you ensure that you have the best quality data, and where are your main worries about data quality in all those very diverse application areas we've just been hearing about? And let's do it in speaker order. So Nigam, then Seema, then Michelle.
All right, thank you, Russ. No, absolutely. Like, without data, without good quality data, all of these models will go exponentially bad outputs because they all have exponential coefficients. Getting the right data has been a challenge, and I will say publicly that US law does not help. Our local counties have been extremely gracious and kind, and our lawyers pushing through data use agreements on a fast pace so that we regionally can share data, but it has still been a challenge. And I would say, I think we should all learn from this opportunity, from this crisis, and make sure that at least at the regional level, as you and I have talked in the past a couple of days ago, we should put in place networks that are already pre-authorized to share data at very short notice so that not all of us have to be flying blind. I mean, that is absolutely critical and a lesson that needs to be learned from this situation.
Seema?
As someone who was a CDC employee, I will say that I know that that agency has the capacity to produce the kind of data that can inform solid models. And what we're seeing here is really perplexing in terms of the agency kind of sitting on the guidelines and in fact data disappearing from the CDC website regarding the number of people who were tested, the number who tested positive. So that's really a hindrance. And for journalists, I urge you all to really dig into what's happening there with the agency and why the US's public health institution isn't being empowered to do its work. I reported a lot on models because models make great headlines. So when you see those alarming models that talk about millions of deaths, often those are the ones that get many newspaper inches because they are quite sensationalist. And I worry about how the public is fed that information without the context of how models are built and just the number of assumptions that we put into them. I wrote during the Ebola crisis about that quite famous model that from the CDC, in fact, that said 1.4 million people would become infected with Ebola. Of course, that epidemic was startling and awful, but nowhere near that many people became infected. When I interviewed those modelers, they said, well, we did that because we wanted to get people's attention. So I think from a communication aspect, there's a lot to dissect with models, and we have to be really careful in offering that context around what the data really means and how it will pan out in real life.
Thank you. Michelle?
So I basically will deal with the global data, because I know there's been a lot of questions. Should we believe the Chinese data? Should we believe the global data? But in actuality, the data that we received from China early on was incredibly crucial as to the first symptomatology, how this virus was presenting. They quickly shared, as opposed to SARS-1 outbreak, this outbreak, they quickly shared the genome. I give them a lot of credit for that, because that helped many people work on COVID-19. There is now a website, because we're all worried about mutation of this virus, called nextstrain.org, where many countries are working together to actually put up the new genomes and the small mutations that we're seeing.
Just to make sure I get that, this is nextstrain.org, as in a strain of virus.
Yeah. I believe that's you can check me, but I'm pretty sure that that's the website. And the other thing is the extraordinary collaboration now with journals, where journals that usually take months to have turnover of publications, we're seeing rapid turnover. We're seeing open access. They're waiving their fees, and there's really rapid peer review. And interestingly enough, there's also non-peer-reviewed articles that are being printed, which we need to take with a grain of salt. But I think the most important thing is to get this information out.
Thanks a lot.
I'm actually impressed with the global cooperation.
I want to move now to some audience questions. We've had a number of different questions come in that try to get at the heart of something that cuts across all of the presentations you've made, which have to do with some of the trade-offs that we have to strike in the face of an emergency like a pandemic. So Nigam, you asked about access to data in order to make much more accurate modeling. That often comes at the cost of surveillance and abuses perhaps of privacy. Seema, you talked about the challenges of a free press and protections for the independence of journalists to do the work that they do, but sometimes that can also pave the way for misinformation and disinformation. And Michelle, some of the various countries that you pointed us toward are not always strong models of democratic governance, and perhaps the more centralized rule there is what permits some of the more stringent measures. So I wonder if any of you wish to speak to the trade-offs that get made in the face of a pandemic, and whether or not, let's take surveillance and privacy or misinformation and disinformation in a free press as a start, whether or not there's a possibility of overreacting in the moment, or whether the emergency just takes precedence and changes the way that societies have to weight these different values.
Right, so that's a really tough call. And when I'm training journalists about how to cover global health crises like these one, I remind them that this is a breaking news situation, and one that's a situation that's familiar to them. And you are making trade-offs all the time there about vetting data as quickly as you can. But we have this adage in journalism that you want to be right, not necessarily first. And that's a tough call. You want to keep your audience as informed as possible. But if you're too quick, you could be sharing information that hasn't been vetted properly. And I will say that as much as we're now seeing flaws in the public health infrastructure, we're also seeing how devastating it is to us that we have had a lack of resources funneled into local news. So in the US, we have these maps of areas that we have defined as health deserts, places where there are vulnerable populations that lack the proper access to care. They often overlap with news deserts, places where local news organizations have been shuttered because of a lack of funding. And that combination is devastating to those communities.
I'm going to jump in here with a suggestion on the technology side. I mean, just like we have legal infrastructure for the governor to invoke emergency powers, for example, and take over, say, a hotel for the purpose of turning it into a field hospital, I think on the technology side, we can have pre-thought emergency powers assignments that enable the administration that any pandemic situation, when the legislature agrees, they can take over certain infrastructure, such as those that tech companies have at their disposal. Like if the governor is allowed to legally command Sheraton to share its hotel beds as hospitals, I believe the governor should be allowed to command a tech company to share their tracking infrastructure for public health for a limited period of time. We have things like the Amber Alert system. Why is it one way? Why have we not thought through about making it a two-way system in an emergency situation so that the administration can get reliable information near real time? All of it is not a technology problem. We have to think through as a society what we want to build in terms of legal infrastructure around it.
Michelle, do you want to address that in terms of the interdependent sovereignty that you ended on?
Well, I definitely think we need interdependence, global governance. But I want to answer the question that the person asked. I think for many years we've had public health laws that take precedence over individual privacy for the greater public good, ever since Typhoid Mary. So that's been longstanding in the U.S. I think what we're all worried about in some of the more authoritarian countries that you may, and there was a great New York Times article about this, is that sometimes it's often hard to unroll laws, strict laws that are made in the time of public health emergencies. It's very easy to roll them out, but we're all looking with bated breath about what's going to happen in the future.
Right. Okay. The standing challenge of any emergency situation in which rollbacks of civil liberties and individual protections in the name of some greater good are often then things that linger far past the emergency time. Let's go to one more audience question. And this one is in particular about journalism. So I'm going to direct it to you, Seema. I'm wondering if you can say something about the way that the contemporary news cycle, in which it's a constant update from Twitter, 24-hour news fractured across many different channels. Is there any special opportunity or challenge in that type of environment as opposed to the kinds of centralized communication that happened in very fewer channels in the past?
I think one of the challenges is offering people context. We see numbers churned out constantly. Those numbers can be useful, but you have to offer people the context as to what those numbers mean, how to interpret them for their day-to-day life. And one of the things that we see regularly during epidemics is shifting case definitions. That's just the nature of how you investigate epidemics. As you gather more information, case definitions change, but that can drastically change the number of cases you're seeing, or at least that you're reporting to the public. We saw this early on with the numbers from China. There was a few days where it looked like the numbers were dropping, and they weren't truly dropping, but we had a very different case definition. So I do worry that there's this 24-hour news cycle, this urge to just be updating information constantly, but then it lacks that nuance that really helps people interpret what the data means.
Mm-hmm. Can I just follow up to that, Seema? You made a really interesting mention of the spreading of disinformation, and usually it's not going to be through the traditional media markets and the media that you work for. Can you tell me what is the sense within let's call it the mainstream media about their duty to snub out any or all or some of that disinformation that spreads through other media like social media and whatnot? It's a complicated, I don't know what the answer is, but that's why I'm asking it.
And just to clarify, sometimes we have seen, so during Ebola, we did see there were newspapers that were churning out conspiracy theories. So it's not, the disinformation isn't always coming from where you expect. There certainly are bad actors. I mentioned that Internet Research Agency in Russia. One of the issues there, though, is that I think we're doing a better job now at debunking some of the false narratives. There's some research that argues that debunking a myth offers it more oxygen and gives it a platform. There's just as much research, though, that says it can be useful. This is a long game. That's why even during a pandemic, I brought up those slides about the anti-vaxxers, because it's a chipping away at belief in science and trust in science. often based on histories that have been unethical in terms of how communities of color and marginalized people have been engaged by the sciences. So it's really complicated and it's rooted in history. We need to be unpacking that all the time, I think, and building health literacy and news literacy so that when it comes to a time like this, we have better relationships with audiences and we're able to say, here's a thing you might be hearing, here's why this is not true, and here's how believing it could be harmful for you. And there's a role for all types of media organizations to do that work.
Nigam, please.
So I would advocate strongly for the need for data literacy. And I mean, this is not something we can do in a pandemic situation, but as an ongoing thing, we teach all of our students to learn how to read, write, and add numbers. I think we also need to teach how to interpret data, and particularly numbers that don't have a reference point or a context, and not be scared by these models that say millions will die and this many beds will be needed. Like as of Monday, California needed 50,000 beds, and as of today, it needs 10,000. That's a 5x difference in 24 hours.
I just want to remind the audience that if they want to ask questions of the panel now or later today, they can go to our website and click on the button to submit a question. Michelle, I think you wanted to get in on the conversation too.
Yeah, I just want to add something to what Seema said. It really has a lot to do also with trust in government. I mean, you can use good media if you have good trust in government. In just watching how Singapore use their apps to tell daily dashboards of what's happening was very important for people to know and prevent themselves from having contact with COVID-19 patients. But you need to have trust in government.
I want to go to one more audience question here, and this was for anyone who feels able to answer this. Many questions have been submitted on a very particular question that individuals can actually act upon. What is the best information we have about the use of masks, either now or in the future, once the curve has flattened?
I'll take that because unless the CDC is about to, I think, put out an edict for masks. I think the big problem, and it's been a really big problem, is that the instructions for masks have been very different for us than the rest of the world. And it has been more for expediency because we don't have enough masks. So CDC took the line that this is primarily a droplet, meaning drops coming within 6 feet or less than 6 feet, and that cloth masks, not cloth, I'm sorry, cloth doesn't work well, paper masks or droplet masks work. I think you're going to be hearing very soon that that's going to be changing. But I don't want to preempt. This is grapevine information. But did I answer the question, Rob?
Yes, I think so. But the basic idea is that if individuals who are watching right now think that they could construct their own mask as a way of doing something rather than nothing, they wouldn't be ill-advised to do so.
That's right. But if you look at cloth masks, I know a lot of people are knitting. It's really not effectual, like 20 to 30% effectual. You really need to get the droplet masks or the N95s. And I think it's really a shame that we are not as prepared as some of our Asian colleagues with giving our healthcare workers who are on the front line the best protection. All of our healthcare workers working with COVID-19 patients should be having N95 and face shields and goggles. That's what was done in Taiwan and Singapore, in all those countries that, in fact, in China, they showed that there was infection transmitted to healthcare workers that dramatically dropped when they enhanced their personal protection equipment. Unfortunately, we don't have that ability.
All right, well, we got about 5 minutes.
Hopefully in the future we will.
Hopefully in the future we will, indeed. Yeah. We have about 5 minutes left before we're going to close this session off. I want to ask one more question that introduces an element that I'm sure we'll get into in the next session as well, which has to do with some of the ethical considerations in the delivery of care. We read stories about how other places that are hotspots are having to limit the use of ventilators because of the lack of the numbers, and whether or not the coronavirus happens to afflict older people disproportionately. really hard choices having to be made in hospitals about who should get access to life-saving treatments. Just as we might think we have a different approach in an emergency, do the ethics of delivering necessary healthcare treatments also change in an emergency like this? And how would any of you react to the news that comes out of places with the hotspots that people are simply unable to get the necessary treatment, and doctors and nurses on the spot have to choose on the basis of what? Something other than guidelines or their intuitions? What's emergency practice here, and how do we think about the ethics?
Well, I think Stanford has done a great deal of thinking about this, and my hearts go out to my Italian colleagues, whom I'm in daily contact with, because they've had to do this on the fly. Fortunately, we've had a little bit of a lull before the surge, so our ethical committees, our palliative care folks, are all meeting now and trying to come up with standards as to who gets ventilators, how we assess who we put on ventilators. There is going to be a tiered approach, and they're working very hard on that right now so that people won't have to do this on the fly. And that takes the pressure off the healthcare worker because they're already stressed out taking care of patients. And it's so hard to make those decisions without an algorithm to make them feel a little bit better.
I would second that. I don't think you want the person delivering the care being forced to make that decision. There has to be a separation between the deliverer of the care and a group that may or may not use both data, algorithms, and individual input to make the call. But the decisions of who to ventilate and not, and the act of doing so have to be separated in order for it to stay on a solid footing.
All right, well, let's end, if you're willing, with a reaction to what the President of the United States said yesterday to the country. President Trump said that the United States should be prepared for a very, very difficult next 2 weeks, possibly month. The messaging from the Oval Office has hopscotched all over the place, and I'm wondering if any of you can, give information to anyone who happens to be in the live stream about what you anticipate in the next 2 weeks or a month, and what kind of messaging you'd like to see from the Oval Office or other central bodies of government. Seema, is it all right if we start with you?
Of course, and I'm just thinking about the direct consequences of that information and misinformation. We saw a man die in Arizona and his wife wind up in the ICU because they said they took medical advice from the president. He said a medicine was approved to treat COVID-19. They had it in their house. They took it. The husband died and the wife is very, very sick. So I worry massively, even about the airtime that's given to these press conferences where officials, politicians say one thing and then infectious disease experts walk to the same podium and have to backtrack. My advice is to be really careful, skeptical about the information you're seeing. Go to trusted sources like the World Health Organization and CDC's website, and be careful about what information you absorb and what you share. And we're seeing just the misinfodemics, right? People with good intention sharing stuff that is not accurate. And I'm just really concerned again about those communities that are already vulnerable because they have access to care issues, then being more susceptible to disease because they're receiving so much misinformation from even the highest levels.
So on the data front, if anything is rising at a 15% growth rate, and we put in place a perfect intervention as of today, after 14 days, things will still be 5 to 6 times worse off than today because of the lag between getting infected and getting symptoms and getting serious. So there's no question that in the short term, things will appear to get worse. That's just the way the math works out here. And in terms of listening to statements coming out from the White House, I mean, the only thing I can say is, monitor for consistency. If a factoid stays the same over 72 hours or longer, it is probably real. if it keeps changing every 24 hours, too much entropy to trust it.
And there's clearly going to be a surge in this country, and the surge is going to be very different in different parts of the country. Just as if I look at the global response, it has a lot to do with density. I think that's why we're seeing New York take off. It's a lot to do with the heterogeneity of our population. We see a lot of deaths in Europe. It's an older population. Older people have a higher mortality in this disease, but we're still seeing young deaths. So remember, it's not just going to be the older people that have the high mortality. And I'd like to end on the sense that it's not just about the US, I'm sorry. We're all in this together as a planet. And we can't forget that. And I am incredibly impressed that the Chinese are flying us over masks and helping us with scientific backup and reagents, which we're running out of quickly. I think once we have a country that has zero antibody positivity, maybe we can even ask them for help for frontline healthcare workers. I mean, we're all in this together. And I wish our administration would take a larger view of this. And ultimately, when this is all over, I think we need to take a larger view of how we do better global surveillance of zoonotic diseases, because all of these pandemics in the last 50 years have come from animals and bats, particularly. And we need to do better surveillance as a world. And for goodness sakes, give our WHO more money than one hospital in the United States. Their budget is basically for the entire world, similar to a large teaching hospital in the United States. So I'll end on a global plea.
Well, I want to thank each of you for giving us your time in this virtual conference today, Dr. Shah, Dr. Yasmin, and Dr. Barry. And to anyone listening, we're going to take a short break of about 10 to 12 minutes, and we'll return with our second session on the social impacts of COVID-19 in just a short amount of time. So thank you once again to our panelists, and we'll see the audience again in just a few minutes.
Thanks.